Good morning, everyone. It's my pleasure today at the UROONCO platform to receive Dr. Schmidt. Dr. Schmidt is a urologist, and she's working in the US at the Huntsman Cancer Institute. Thank you very much, Bogdana, to be with us today. It's really a pleasure to have you. We're going to discuss a bit about a recent published study that you have performed in real world regarding Nadofaragene firadenovec. So please, Bogdana, can you tell us a bit about what's happening with Nadofaragene in US compared to what we have so far in Europe?
Thank you so much for having me. I'm super excited to be able to talk about this and share our experience. And it was the first intravesical gene therapy approved for BCG-unresponsive non-muscle invasive bladder cancer. Because it was the first drug in the space, that initial trial protocol was very cautious by current standards. And what I mean by that is if a patient did not demonstrate response at the initial assessment, the 3-month cystoscopy, the 3 months after one intravesical installation, the patient was taken off trial and basically deemed to be a non-responder and then go on to be observed as their outcome, but was directed towards standard of care per the treating physician. Other drugs that came to follow, specifically NAI, the nogapendican, and now currently cretostimogene that is currently under trial, they did something different. They said if the patient initially didn't respond, they were able to reinduce the patient, meaning give them another dose, another treatment attempt. And we know that from our old experience with BCG, that was very common practice, right? If the first induction doesn't work, let's give a little bit more. And some patients are able to be salvaged with that approach. With BCG, with cretostimogene, with nogapendican, there is a percentage of patients that can be converted to a response after an additional induction dose. So what we did with our 7 to 8 physicians who have had some experience using nadofaragene is we decided to go back and look at our data for the patients that we reinduced, obviously not on trial, off protocol after the drug was approved, and look back at our experience, meaning how many patients were we able to convert to a responder after giving them a reinduction dose.
So that's what I really like in your study. This is just the real life, the clinical experience that you have, and I think it's very important that you're being able to publish very early some feedbacks on how to manage this patient that have finally an early recurrence, more or less. So can you tell us a bit about the study? How many patients did you find who had this reinduction? The reinduction, so as you said, was based on the expertise of the urologist who decided to give a new try with nadofaragene. How many patients did you find, and what was the profile of these patients?
Yeah, so these patients, there were only 17 patients across 8 sites. And this was between December 2023, which is when nadofaragene was approved and entered most of our clinic space, and the follow-up ended in June 2025. All of these were BCG unresponsive, and most of them got reinduction after visible disease at 3 months, so that initial assessment, or one patient had an initial response, so the 3-month looked good, but then the 6 months there was something concerning, and so basically they had a recurrence following an initial complete response. Now, the patients here, 13 of them had CIS plus or minus papillary disease, and papillary only, we had only 4 patients. So again, these are very small numbers. But what we saw is in that CIS plus or minus papillary rate, the response rate after reinduction was about 38%. And those with papillary only disease, 75% were free of disease at the 3-month mark following reinduction. So if we combine the cohorts together, the overall 6-month RFS was about 53%.
Okay, and that's a very interesting data that you found. Also, I like the fact that most of the patient, I think 65% of the patient had a recurrence at 3 months cystoscopy. So
correct.
It really means that we need to still have a very close follow-up for this patient. Do you also, in your daily practice, use biomarker for these patients that are treated with nadofaragene?
I don't. I don't believe that any specific biomarker has been validated in this cohort. So I don't use anything specifically for this patient population. I'd love to have something. One of the benefits of nadofaragene, at least in my practice, which is a referral practice and what I call a long distance practice. So a large number of my patients travel multiple hours to come to our clinic. So I take care of patients who don't live in the same state in which I practice, where having a treatment that you offer once every 3 months is a tremendous advantage. And truthfully, for me, the idea of doing reinduction was actually patient driven, because I had a patient who had persistent disease at 3 months who said, well, can we just try it again? Because I can't come for a 6-week induction. I can't take this much time off work to be able to travel for this. Let's try it again. And so the question for me was, well, is it safe? Is it safe to try it again? Or am I going to spend these 3 months and this patient is going to progress to muscle invasive disease or develop metastasis? What is really the safety profile? More so than I was thinking at the time is, what's the efficacy of trying it again? I was more on the back end of saying, well, can we do that again? You didn't respond. Am I wasting time? Am I going to hurt you? And so to me, that was driving my desire to look at this experience among other patients, because I knew I was doing it with my patients and I was kind of nervous about doing it. And so when we pooled our data, for me, the fact that some patients responded was great. But what I really was grateful for is that we didn't see a large number of our patients progress to needing cystectomy, to having muscle invasive disease, to developing metastasis in that short follow-up window. I understand the follow-up's short, but I'm looking at it is it safe to do this for 3 more months? Short matters.
Yeah, that's a very good feedback as well. That although we have very few patients, to see that there is just one patient who progressed to muscle invasive with a cystectomy, but no metastasis. I had a question. I also see that it seemed in your real world evidence data, that you have more effect in patients who had a papillary disease more than CIS only. Do you think that the adenoviral vector works better if you have a better penetration uptake in papillary disease, or is it just like because we have a very few number of patients?
I think it's twofold. I think the overall disease profile of papillary disease is better than CIS, right? I think just in general, papillary tends to be luminal-based tumors that just tend to have a better prognosis. And 2, I think that we have too few patients to really comment on whether I think there is a favorable performance in this patient group overall. That being said, there was a paper that was published at the papillary-only patients with nadofaragene that did overall demonstrate a good response, and the patients in the initial, trial cohort. So I think that data exists, that the adenoviral vector does not work inferiorly in that patient population. But I don't think it's that the adenovirus is better in that group. I think that just in general, the disease is better in that group. That's my opinion.
Yeah, I totally agree with you. Do you think so? The recurrence-free survival for patient who get the reinduction was around 53%, if I get well in the
53% at the 6 months. You're correct.
53% at 6 months. In your practice, maybe that's, of course, that's just your own expertise, but we need this kind of very high expertise to go through this kind of patient. Would you, if you have a recurrence and there is a failure after reinduction, what kind of treatment would you propose to your patient in case they don't want a cystectomy?
Yeah, I think that's the first decision point, right? Is you talk to the patients about cystectomy, because now they've failed BCG to have had this drug in the first place. Now they've progressed on this. So I think the first conversation is cystectomy. The second conversation, if cystectomy is off the table, either because the patient's not a good candidate or the patient refuses that kind of intervention, then I think you have to get a little bit creative. In my practice, if I have a clinical trial open in that space, then I will offer a clinical trial to that patient, especially if they're willing to enter that environment. One, I think it allows us to keep very close tabs on the patient. And two, I think that outside of evidence, we really don't know how to sequence these other agents. So I tend to use chemotherapy. I use gemdosi quite a bit in the patients that can come for those visits to receive it. Now that the TAR-200 is approved, TAR-200 is another alternative. In my practice, nogapendican, less so just because of the BCG shortage. I do think that their profile and efficacy is just in line with everything else, and I think it's a good alternative for the providers and patients who have that available.
I agree. But I think this is also opening a lot of questions, because we have now this viral therapy, gene therapy, immunotherapy, and potentially there is a place for a sequence of treatment in this field of BCG-unresponsive, where we, for example, especially I would have with friends, but we have gemdosi as an alternative if we have no clinical trials. So this is a real question to go. Do we go to viral? Do we have to go to immunotherapy, chemotherapy? And the sequencing is a very real question that we have to discuss, as well as the re-challenge as well. Do you think that according to your data and taking into account that probably you're going to bring back more data in the next coming months and years regarding the use of reinduction with Nado, do you think that the reinduction should be a real contemporary option to be proposed for this patient with a recurrence in after first Nado? Or do you think it needs to be really discussed in very specific cases, expert center? I know that in your trial there were some academic centers, but also some community sites, and that's where also big experts see a lot of patients. So just to have a bit more so that you can frame for us the indication.
In my thinking and the way that I discuss this with my patients is, I think that for most patients, this is reasonable to do. I think reinduction is very reasonable for most patients. The patients, for me, where I would hesitate is that T1 CIS patient population. If the patient went from TA to T1 CIS, right? If somebody progressed as opposed to recurred after their initial induction, I would hesitate to reinduce that patient. I think that speaks to disease biology, and I worry that we could be wasting valuable time and that therapeutic window of curing the patient of their disease with a cystectomy in that time period.
Yeah, I think that's a very good point that you say, and I believe in it. And it's very difficult for us to right now have a better explanation than the one you propose here. It's in your opinion, do you think that there are other drugs in that settings that needs to be also I would say assessed in real world to get more reinduction? Because you're right, everyone wants to have reinduction or a new try and give it a new try. Although we don't have any data regarding the sequencing of different new therapy in that BCG-unresponsive setting, what do you think? Which drug would you like to address in terms of reinduction as well? And do you think there is a room for something else before cystectomy in bladder spotting strategy?
You know, all the current protocols of the drugs that are going to be FDA approved that are immune mediated or immune based mechanisms, they all include reinduction. And I think that the chemo ones don't, just based on the mechanisms of it, right? I don't think that makes mechanistic sense to me necessarily to reinduce chemo. Now, but that being said, and this is where I think we're all going to have to answer this question, is the patients that we have who got BCG, became BCG unresponsive, got gemdosi. Now we have the TAR-200 approved. Would you try TAR-200 in that patient if they've already received gemdosi? To me, that's effectively almost a reinduction, not the same thing, obviously, right? But it's trying the same mechanism in that patient. Exactly. And so I think that we don't have certainly prospective data to guide us in that way. And I think that it would matter for me, what is it that they are recurring with? Is it a papillary-based recurrence? Then I think it makes more sense. If they're progressing, you're getting to that T1CIS cation category, I would not favor trying the same mechanism in that patient. Okay. But I'd love to have more biomarkers in that space to help guide decision making.
That's very hard. And a last question, because it's something that we have discussed a lot recently with in the BCG naive setting. You know that the Potomac and the CREST trial decided to have as a primary endpoint recurrence only on high grade. The Alban trial included also low grade as an event. And so my question is just on a daily basis, if you see a patient under NADO and he has a multifocal PTA low grade, will you reinduce the patient with NADO, or will you change?
I keep going. I mean, low grade recurrences don't scare me. I think that they don't tend to limit our patient's life as much as the other recurrences, obviously. And the big advantage of Nadofaragene is the formulation, the Q3-month formulation. So I don't want to take a patient with low-grade disease and now commit them to more frequent visits necessarily, right? I think that's where you talked about maybe continuing, maybe doing some fulgurations in the office. What you really care about for me in that setting is making sure it really is low-grade, right? You don't want to miss a multifocal high-grade recurrence just because it doesn't look aggressive on system.
Thank you very much, Bogdana. We have made a full overview of how to manage these patients. I really look forward for more updates of your data set, because I believe that it will help us a lot, especially in Europe as well, where we don't have it so far. So when we will be able to use NADO, I guess we will have a lot of feedback from your studies, and they are very important today. So thank you very much for your...
And actually, I was going to point out that you are going to have more robust data than just mine. So they are doing a ABLE-22, I believe, is a follow-up study. So actually looking at these real-world outcomes in an organized, prospective, more layout in a much more robust way than just our 17-patient experience. So I do think that that data will come over time, and I expect it to be very useful. I'm looking forward to it as well.
Yeah, that's fantastic. Really looking forward as well. Thank you very much, Bogdana, for your time. It was a pleasure to have you at UROONCO and to benefit from your expertise. And I hope to see you soon.
My pleasure. Thank you so much for having me.